thank you for the invitation for a brilliant meeting, as usual. Yes, my task is to talk to you about Complete versus Culprit in primary PCI. These are my conflict of interest. Now, these are not moving. Okay. Sorry, my slides are not moving. Thank you. Right, so we know that approximately 50% of patients presenting with acute MI now have multivessel disease. And does that affect the outcome? Of course it does, short-term and long-term. You could see some of the short-term effect in terms of additional black instability, the impaired myocardial perfusion, and decreased contractility in non-infarct zones. And the long-term prognosis also is affected because there's more atherosclerotic risk factors, more future events, and also the left ventricular function is impaired because of multivessel disease. So, and of course, if we look historically how we started treating myocardial infarction, it was, first of all, it was bed rest and only conservative treatment. Then thrombolysis came along. Then we started doing it by BTCA, i.e. just POBA and so on. Then stents came in, and primary PCI became the norm for treatment. And of course, once we've achieved that, then you start thinking, do I need to do complete revascularization or not? And the next step becomes when, which is the timing of when you do this. So this is where it all began years ago, and I think it was in mid-80s, where thrombolysis came along, and it did show some benefit, about 10% reduction in outcome, and that's what became the norm. After that came the PAMI trial in mid-90s, where primary PCI was performed only with the balloon angioplasty, and again, that did show mortality benefit, 17% in the thrombolysis versus 9% in the balloon angioplasty. So that became the norm. After that came the PAMI stent trial. And of course, again, that showed reduction from 15 to 20% to 2 to 3% at 1 year. And that this introduced us to the primary angioplasty, and that became the norm for all treatment. And of course, the current guidelines does recommend complete over culprit only revascularization, because that strategy is deemed to reduce the risk of MACE, the future myocardial infarction, and need for repeat revascularization. But does this happen all the time? Of course, there's the only exception now is the cardiogenic shock. Often we used to treat cardiogenic shock doing complete revascularization, but this has been shown in a couple of studies that it's not as effective, could be in fact detrimental. Of course, stage complete revascularization is superior to culprit only treatment. This was shown in a couple of studies, and I'll come to that in a minute. So do we do stage or immediate complete revascularization? Stage angioplasty, it depends, of course, on where you work and how your setting is. Ideally, if you look at the studies, and of course, we could always look at the study and find the difference in the outcome and how they conducted, etc. But stage BCI is common and effective strategy. And the immediate one does show that benefit with complete revascularization as is safe and effective, but in selective patient. And of course, this is the important bit. It's not in everyone. This is toward preventing with the PRAMI study, which took part of it some time ago. Of course, this was published in the New England Journal, and the treatment of non-culprit arteries of more than 50% stenosis reduced the combined rate of cardiac death, non-fatal MI, and refractory angina by 65%. But at that time, this study was stopped a little early, and also the selection was quite biased because, I said, we took part of it, and sometimes if somebody during the night, you don't do it because nobody wants to stay there for 2 hours doing complete revascularization in comparison to doing during the day. And this is one of the kind of criticism about this study. The culprit trial, immediate complete revascularization versus culprit only. Again, this was done by the late Tony Gerchlik in Leicester in the UK. And again, this shows difference, as you could see in the graph on the left here. Although the numbers were not as big, nonetheless, this became almost the norm, and everybody was quite excited about doing this. Then came the Dynami 3 trial, which is, again, this was FFR-guided complete revascularization. The same thing showed similar event in the infarct-related group to culprit trial infarct-related group. And of course, the question became, was the FFR correct in these group of patients? Because as we know, during acute ischemia, FFR might not be the best assessment to the coronary artery because of the effect on the microvasculature and the flow, etc. Nonetheless, this was the outcome from this, and it did show some, if you do complete revascularization, there was a benefit. And then became the complete culprit only versus immediate complete revascularization. This is the shock in STEMI, and this did not show much benefit. And this is where now the recommendation is not to do full revascularization in acute MI and acute cardiogenic shock, because the outcome is not as good. And that's kind of intuitive. If you have an infarct-related cardiogenic shock, there's a big myocardium that's affected. You try to affect the other part of the myocardium, and that could be detrimental. So this has become much less just to do the culprit in acute cardiogenic shock, and to come back to it a little later. And then the timing, of course, becomes an issue here. In the complete trial, complete versus culprit, and the only trial effect on MI and mortality. And this was showing significant reduction in MI and cardiovascular death by 26%. If you look at the graph on the left side here, again, culprit only had about 14% in comparison to 10%. So this became, again, the norm, where if you have a myocardial infarction and somebody coming with multivessel disease, you should go ahead and do the full revascularization. The multi-star, again, in this is complete revascularization MI, 48 reduction in primary endpoint. So you could see the trend is showing us in multiple studies that if you do this, complete revascularization is probably better if you do versus doing stage. Now, the optimal timing of complete revascularization in myocardial infarction, again, became the subject of this study, the option STEMI. And if you could see that the stage, there was no difference whether you do it immediately or you do it as a staged approach. And the staged approach, there has been multiple studies. Some do it within a day or two, some do it within a week, and some up to 3 months. And again, with this study particularly, there was no significant difference in whether you do it immediately or later on. And this is the study itself. You could see all the sub-analysis of all the group crosses the line, so there was no significant benefit that will tell you should be doing it immediately. So again, the immediate versus, this is in ACS, a little bit different to the acute myocardial infarction primary, but nonetheless, this was done in acute coronary syndrome, the BioVasc trial, and again, this showed that the stage complete revascularization is not as good as if you do it immediately. So in acute coronary syndrome, there may be a case to do it also. And this is a meta-analysis of immediate versus complete revascularization. And you could see again, if you look at the outcome, all of it, it all crosses the line, and indicating there isn't a huge difference in whether you do it immediately or as a staged. Nonetheless, as a complete revascularization, there's always a benefit in here. So if we were to summarize the evidence in here, okay, in hemodynamically stable patient with no heart failure, immediate complete revascularization may be superior to stage strategy. I say maybe, and I come to this. Why am I saying that? Because it's not always possible to do this, depending on where you work, how the setting in your center, and how you practice. But in patients with sign of heart failure or cardiogenic shock, a strategy of initial culprit PCI and complete stage revascularization is probably better and more appropriate based on few studies. And these findings are also applicable non-STEMI, as you said. The BioVasc ACS did show us that if you do complete revascularization, the outcome is going to be better. So if you look at it in general, of course, complete revascularization, where you treat everything, you don't leave, you treat the culprit as well as any other disease. And we could argue and say, well, how do you know it's significant? How do you know it's not? The study with the FFR was not as conclusive, and the criticism was whether FFR does give you the same outcome if you're doing it within acutely or later on, but versus the culprit, where you only treat the culprit and come back to the other disease later on. And of course, the recommendation says that complete revascularization is superior in patients with multivessel disease. But of course, there are situations where it is not the right thing to do. And we all use our clinical judgment. And sometimes, as I said, the time of the day makes a difference. At 2 o'clock in the morning, you don't come and start treating calcified and tortuous arteries and multiple complex disease. This is just reality. So of course, the benefit for this comes from the reduced risk of cardiovascular death and new MI, reduced risk of cardiovascular death, MI, ischemia-driven revascularization, and improved outcome. Versus if you do the culprit only, it's safer in patients at high risk. And of course, the potential harms are there. We all know that if you're doing more than one vessel, there's increased use of contrast, increased use of bleeding, nephropathy, immediate, which may affect or offset the benefit if you're doing complete revascularization. Of course, if you don't do it, there's increased risk of subsequent myocardial infarction if the other lesions are left. And there was a very nice, elegant publication a few years ago now, but this is from was published in JACC, and it really summarizes this very, very well. And it tells you the pros and cons of all these. If you do it complete revascularization, if you do the culprit only, you're only going to use a minimum amount of contrast. You stabilize the patient, and you could always come back and do it later, but there is an increased risk of repeat revascularization risk and potential reduction if the left ventricular recovery. If you do multi-vessel at the same setting, there's reduced revascularization and decreased hospital length. However, there's prolonged procedure time, more contrast, potential risk of complication, and increased risk for the patient, which might offset any benefit. So really, overall, the stage PCI, you're thinking about if you bring the patient again, you're doing it again. So there's the risk for the new procedure becomes the same as any other procedure, and so on. So in summary, culprit primary PCI remains a solid strategy for the majority. So immediate revascularization may be an option in selective patients, and I emphasize the word selective because not everybody is the same. And I always think about it practically. If somebody is coming with an area that is really compromised because the artery has been blocked, you try to do an angioplasty in the other artery, introducing more ischemia and more problem in the other territory, it might not be the best thing to do. Stage PCI for non-culprit lesion is a good and valid approach. And if you decide to do complete revascularization, it is justified. So this is how I look at it right now. It gives me if I want to do complete revascularization, there is an evidence to support this. But again, in our practice, we do one of the highest centers in the UK. We do about 750 to 800 primary a year. And if you're going to spend 2-3 hours on every patient who comes with MI, I think the ACS list and even the elective list will be quite effective. So I think, again, this is what, to me, if you want to do complete revascularization in selective patients, it's well justified, but I don't think it's wrong if you leave it and come back and do it another time. And with this, I think, thank you.